Welcome back. And being here is like going on a train in Sweden. We are a bit late, and we are 30 minutes late. So the lunch will you will get lunch, but it will be 30 minutes late. So, next speaker, it's an honor for me to present Elisabeth Norman. She is a senior consultant in neonatology here at our hospital in Lund, Malmö, and she has been working with neonatology for over 25 years. And early in her career, she was very interested in pain relief, and the pharmacogenetic behind all the medication we put in the small babies. And as you know, we leave footprints out on internet. And I will just read a few footprints that Elisabeth has left on internet. Newborn infant, premature infants, thiopental, electroencephalic EEG, intubation, pain, rapid sequence induction and intubation, pharmacogenetics, pre-medication, morphine, procedural pain, and more and more. You are most welcome.
Thank you so very much, and thank you for that introduction. You know, coming after not two giants, I would say three giants, with a common heading or message of love and communication. It feels a bit like a challenge to discuss the latest evidence on the pharmacological strategies for mitigation of pain. But I'll try to do my very best, and I'll see if I do it this way. Yes. The latest strategies and the latest evidence-based, there are some pictures that deserve to be repeated. It is not so long ago that Professor Anand considered the whole world that newborn babies really can feel pain and that they deserve pain relief during operation and in the postoperative period to have better postoperative outcome. See if is this, yes. We are today very aware that pain matters and that it results in both short-term and long-term complications. Here we find a summary of the principal cerebral findings in neuroimaging studies in infants born very preterm. 9 of these studies are clinical studies conducted during neonatal care or at school age. Most of those studies are conducted and coming from the same research group in Canada led by Ruth Grunau. They all revealed a reduction of white matter and gray matter, and all those findings were correlated to cumulative pain during the neonatal period. There are also growing evidence that the analgesic and sedative drugs that we administer to reduce the pain and stress also can result in reduced pain development and poorer follow-up results. As an example, here 136 neonates were serially scanned with MRI near birth and at term equivalent age. A 10-fold increase in morphine exposure were associated with 8% decrease in cerebellar volume after adjustment for multiple clinical confounders and total brain volume. Greater morphine exposure also predicted significantly poorer motor and cognitive outcomes at 18-month corrected age. Already in 2006, Professor Samsa van Hattalo published data on that features of brain activity, the discrete spontaneous activity traits called SATs, were essential for brain development. Dr. Wikström here in Lund showed some years later that a more inactive EEG with a cerebral depression and longer interburst intervals assessed already at 24 hours age is associated with long-term outcome in very preterm and extremely preterm infants. There are many nice studies on this area of research, and the NeoBrain study may serve as one example. The research group studied preterm infants in 3 European tertiary NICUs. 174 preterm infants were enrolled and connected to an EEG within 3 hours of birth. 6 periods were selected for analysis during the first 24 hours. 51% of the patients received morphine on clinical indication, and the morphine dose was calculated as total morphine dose over 3 days. In these pictures, we can see that the patients receiving morphine showed significantly longer IBIs, interburst intervals, and a depressed activity in the EEG, and that was related to the cumulative morphine dose. The same infants underwent MRI at term equivalent age, and the findings show that cumulative doses of morphine until TEA had a significant effect on the total brain volume and on the cerebellar volume. The dot plot is showing cumulative morphine doses in relationship to total body volume and cerebellar volumes at TEA. And the box plot refers to the patients who did not receive any morphine. The authors concluded that administration of sedative drugs should be considered when interpreting EEG together with a negative dose-dependent morphine on brain development. The same group conducted a retrospective single-center follow-up study on 106 of those infants. Neurodevelopmental outcome was assessed at 2 and 5 years of age, and morphine exposure was significantly associated with lower full IQ scores and performance IQ scores at 5 years of age. Similar results have been shown by fentanyl, by, for instance, McPherson in 2015, and it seems we see them also in the benzodiazepines. A total of 138 neonates underwent MRI and diffusion tensor imaging scans at 32 weeks of age and at term equivalent age. The total midazolam dose was significantly correlated to decreased hippocampal volumes and increased mean diffusivity. Lower cognitive scores at 18 months of corrected age were significantly associated with hippocampal growth, midazolam dose, and surgery. The same group published new data in 2023. The same infants underwent MRI and neuropsychological testing at 8 years of age. And it was shown that reduced hippocampal volumes and lower working memory scores were significantly associated with neonatal midazolam dose. So, with this growing evidence regarding, on one hand, the negative consequences of painful experience, and on the other hand, those of exposure to analgesia during neonatal intensive care. With this, we end up with a delicate balance of pros and cons, how to further improve our strategies for those vulnerable infants. The treatment we provide our sick infants with is still more experienced than evidence-based, and we lack both national and international evidence dosing guidelines. It is important to underline that these drugs shall be used only when needed. This triangle demonstrates, it's about the same as your ladder, Professor Anand, and it demonstrates the total of the strategies for the mitigation of stress and pain in the NICU. It is, of course, as important for the sick term infants as for the preterm infants. In the daily routines, we all, as a team, together providing the infant and the families with adequate planning, basic management, optimal non-pharmacological care, communication, love, all this, but when needed, of course, also with sedative and analgesic drugs. Following the multimodal balanced approach, we are entitled always to start with the non-pharmacological support and the optimized care strategies. If needed, as said, also pharmacological treatment should be used, and this should be individualized and according to the individual age, clinical condition, and state. It should be titrated according to the instruments that we have, the pain scales in this area, and also which should also be validated. It should be titrated in doses as low as possible, but large enough to be effective, and optimally with drugs that are tested and considered safe in this patient population. Unfortunately, most of the drugs that we are using are still off-label, despite the EMA regulation of 2006. Sometimes multipharmacy is preferable. Using the additive effect, lower doses of each drug can be used, and we can prevent side effects, normal side effects, but also tachyphylaxis and abstinence. So what we really aim at, according to the research results that we have, is to reduce the amount of opiates as much as possible. Necrotizing enterocolitis is considered one of the most painful conditions in the neonatal population. This study, on behalf of the ESPR Special Interest Group for Neonatal Pain and the Neck Pain Study Group, aimed to describe current pain management for neck patients in the European NICUs. An online survey was conducted, and of the 259 responding NICUs from 36 countries, 61% had a standard protocol for analgesic therapy. 73% assessed pain during neck, and 92% treated neck patients with intravenous analogous sedatives, including paracetamol, fentanyl, and/or morphine. As you see, we still do this very differently. It seems that the countries in the Central Europe are using more morphine, whereas Finland and countries of the Southern Europe are more prone to fentanyl use. It is very satisfying, I think, to see that most NICUs are using paracetamol as part of the treatment strategies. Sweden is not presented here, as you can see, most probably due to a bad response frequency. In Lund, we use a combination of paracetamol, fentanyl, and clonidine or dexmedetomidine for postoperative care and for the neck patients. And if we have to use a prolonged strategy with opiates, we switch over to morphine after a week to avoid tolerance and abstinence. Paracetamol is one of the drugs where we really have evidence-based dosing guidelines, very much due to the Dutch group led by Karl Algert. But we also know that it is not suitable for procedural pain. In a blinded randomized controlled trial of 60 very preterm infants, the analgesic effect of 10, 15, or 20 milligrams per kilo single-dose intravenous paracetamol before a PICC line placement were compared. A separate age-matched control group received oral sucrose and was included. And no analgesic benefits were found with paracetamol as compared to the sucrose. In a review as late as 2020, once more paracetamol was considered ineffective for procedural pain. We do not fully know the analgesic mechanism and the effect of the brain by glucose or sucrose. Until we know, I suggest that it's strongly recommended that we do treat sucrose, glucose as a drug. It should be ordered, dosed, administered, and also registered according to the best evidence. To be effective and not harmful, it shall be used according to guidelines in a well-controlled amount, not too much, not too little, and in a combination with non-nutritional sucking. We thought that we knew everything about dosing of paracetamol down in the very extremely preterm infants. Until this study came by Wu and collaborators, data sets after single or multiple doses of intravenous paracetamol were pooled from 143 preterm neonates with a median birth weight of about 1 kilo and a postnatal age of 5 days. Population pharmacokinetic analyses were performed using non-MEM. Between 500 and 1500 grams of birth weight, the total paracetamol clearance increased from by 170%, most importantly from glucuronidation, increasing with most with 350%. From 1 to 30 days of postnatal age for the same baby, total paracetamol clearance increased by 167%, with clearance via glucuronidation increasing by 551%. The authors conclude that dosing based on only body weight will not lead to consistent paracetamol concentrations among preterm infants. In this picture, they show the model-derived paracetamol dosing regimen for preterm infants less than 22 weeks of gestation for the first month of life, taking both body weight and postnatal age into consideration. Another old picture that qualifies to be repeated. Paracetamol is nowadays indicated not only for mild or moderate pain conditions. Since this study, it is obvious that paracetamol should be part of and serve as a base in a multi-drug strategy when painful conditions such as postoperative pain. In an RCT, the infants were all given morphine, followed by either a morphine infusion or intermittent intravenous paracetamol. Then morphine was given as rescue medication according to pain assessment results. And the result was that post-operative use of intermittent intravenous paracetamol compared with continuous morphine infusions resulted in a lower cumulative morphine dose in the paracetamol group. So we can reduce the morphines by adding paracetamol as a base. We learned that paracetamol is not procedural effective for procedural pain. Here is another study on morphine. Since the finding also showed by SANNI and the NeoPain group already in 2005, we know that morphine is not effective on procedural pain. In this POPI study, conducted by Hartley and Fitzgerald in London, infants received morphine and were monitored with a multimodal monitoring strategy, heart rate, saturation, blood pressure, and EEG for heel lancing, and during ROP examination. And the authors concluded that administration of oral morphine of 100 micrograms per kilo to non-ventilated preterm infants has the potential for harm apneas without analgesic effect. Again, a Dutch group published new PK data, pharmacokinetic data on fentanyl. 164 newborn infants were pooled and 673 plasma samples were used for population pharmacokinetic non-mem modeling. They concluded that as both prenatal and postnatal maturation are important for fentanyl exposure, we propose a birth weight and postnatal age-based dose regimen, although fentanyl is a drug with a quicker onset compared to morphine. Fentanyl concentration increased slowly after continuous infusion is started, and additional loading doses need to be considered to provide rapid analgesia in the first 24 hours of treatment. We need to bolus dose before we start the infusions. The recommended dose of fentanyl would be a total of 5 microgram per kilo, divided into 2 separate doses with a dose interval of at least 5 minutes. This is a rather high dose to be in Sweden. By tradition, opiates and benzodiazepines are mostly used to control continuous pain and stress for both preterm and term infants in the NICU. Given the negative effects of these drugs and repeated meta-analysis and review data, it seems reasonable to question this heavy treatment, and its use should be selectively dosed according to pain assessment results. We need to, as you've talked about this morning, we need to be close to the infants, to read the infants, to meet them with other strategies, and only if needed, use the heavy drugs for consoling, for giving comfort. With all this evidence for doing bad with opiates, we are very prone to reduce the opium burden. The last 10 years, the alpha-2 agonists have entered the NICU. The effect is mediated through alpha-2 adrenergic receptors located in the lucus ceruleus in the pons of the brainstem, the main site for brain synthesis of the stress hormone noradrenaline. There are both a limited experience and evidence for the alpha-2 agonists in term and preterm infants, but it is suggested that they may provide an analgesic and sedative effect on its own and in combination with other drugs. The fact that they also might be neuroprotective, as seen in animal studies, and also have an anti-inflammatory effect could be an additional potential advantage of great interest in the vulnerable NICU population. The two main adverse effects are hypertension and bradycardia. In Sweden, we've used clonidine since more than 10 years now, whereas dexmedetomidine has entered the area the last few years. The only study conducted on clonidine in newborn infants were conducted by Hundseller and published by Hundseller and collaborators in 2014. They published data on an RCT in 3 groups of sick newborn infants and older infants, and could show that the group of newborns, specifically, the amount of fentanyl and midazolam was reduced, and that scoring results were better. Dexmedetomidine is an interesting new agent that is used increasingly since some years, and I think it's more used in the States than it has been in Europe, but it's entering also the NICUs in Europe, I would say, because it has been for a long time in the PICUs in Europe. A multicenter observational cohort study was conducted in inborn preterm infants born at any of 383 NICUs across the US between 2010 and 2020. A total of nearly 400,000 infants with a median gestational age of 34 gestational weeks were included in this analysis, and there were 384 infants who received dexmedetomidine. As you see at left, dexmedetomidine exposure increased significantly during the study period. Clonidine use also increased, while the overall opioid exposure decreased. To the right, you find a review of OIA, including studies in both preterm and full-term infants from the States, except for one in Canada. From 9 studies, they concluded that the DEX treatment could lead to less need for or a reduced amount of a shorter period of opioids and benzodiazepines, shorter ventilator periods, earlier establishment of full enteral feeding, less abstinence, more bradycardia, but leading to a discontinuation in just one of the studies, and that was just a few patients during hypothermia, which might, as you know, give problems per se. A single institution retrospective study of preterm infants born before 28 weeks of gestation was conducted to compare the complications and efficacy of DEX versus fentanyl. Patients were administered fentanyl before 2015 and dexmedetomidine after 2015 as a first-line sedative. 66 infants were enrolled into the study, and the composite outcome of death or developmental coded less than 70 at corrected age of 3 years were not significantly different. Postmenstrual weeks at extubation didn't differ, but on the other hand, the period of full feeding was significantly prolonged by dexmedetomidine, and additional sedation was significantly less common in this group. In the graph, you can see that fentanyl is hemodynamically more stable, but the differences are not significant. The treatment of discomfort and often irritability during hypothermia is a problem, and it's a challenge for all of us. In a review from 2023 by Yoshi, it was shown that there is an increasing trend towards routine analgesic during hypothermia. The most frequently used pharmacological agents are, as you see, opioids, midazolam, fentanyl, morphine, fentanyl, and midazolam and dexmedetomidine. They stress that hypothermia alter the most drugs' metabolic rate and clearance except for midazolam. Dexmedetomidine seems to have benefits of thermal tolerance, neuroprotection, faster recovery, and less likelihood for seizures. We know since many years from ROCA and from FAVI and many more that drug metabolism is reduced by both the asphyxia and the hypothermia that we are treating those asphyxiated infants with, leading to a considerable accumulation, and that a low dose of morphine, 50 micrograms per kilo, followed by 5 micrograms per kilo per hour of morphine is a recommendable dose. However, in 2021, this article was published by the Bristol Group, who are the very specialists on this research area. They presented data from a population-based study with patient inclusion from 2007 until 2017, and 282 infants undergoing hypothermia were analyzed. All infants were intubated and cooling started with less than 1 hour of life. Morphine starting dose was 50 micrograms per liter as a bolus, and then they increased this dose that was recommended and gave them 20 micrograms per kilo per hour. During the inclusion period, the opioid use changed, and fentanyl was added gradually, as seen in the diagram above. Cumulative opioid dose of morphine and equipotent fentanyl was calculated during the first week of life. Time to extubation after rewarming was independent of cumulative dose of morphine. Let's see if I can manage this. I'm so used to. In a previous PK study, it was shown that with an infusion rate of 5 micrograms per kilo per hour, 81% achieved morphine concentration of 10 to 40 nanograms per milliliter, which was considered recommendable. Because of the much higher doses in this study, the concentration were extrapolated and ranged from 120 to 240 nanograms per milliliter, as seen in the diagram below. Importantly, higher cumulative doses of opioid doses in those hypothermia-treated infants with hypoxic ischemic encephalopathy was not associated with worse Bayley-III scores at 18 to 24 months of age. This is very thrilling, or how to express it, it's surprising data. They gave a lot of opiates, and it did not result in any bad scores. We will most probably always need the opioids and to meet the strong pain. But there are new agents that might help us meeting stress and milder continuous pain during NICU care, for instance, during ventilator support. And also as an add-on to help us reduce the opioids to compare with the alpha-2 agonists. Melatonin is a natural human neurohormone secreted by the pineal gland. It acts both directly on melatonin receptor and other receptors distributed in the pain control regions of the central nervous system. And it also acts indirectly through its anti-inflammatory and antioxidant effects. The analgesic effect of melatonin during endotracheal intubation and mechanical ventilation was evaluated in 60 preterm infants already in 2012. Two groups treated with melatonin and fentanyl versus fentanyl alone were compared during 22 hours of invasive ventilation after the procedure. Scoring the procedure, there were no significant differences, but during the 22 hours of ventilation, the scores were significantly lower in the group of patients treated also with melatonin compared to the only fentanyl-treated infants. And in a recent RCT from a Turkish group, treatment with surfactant versus surfactant and melatonin was compared in a group of preterm infants. BPD, bronchopulmonary dysplasia, was diagnosed in 60% of the neonates receiving only surfactant versus 45% in the melatonin group. The duration of hospital stay, need for mechanical ventilation, and mortality were significantly lower in the melatonin group. During the last couple of years, 2 separate studies have been published on melatonin in infants with hypoxic ischemic encephalopathy. In 2018, a Pakistan group published data without hypothermic treatment, and they received standard treatment, which I don't really know what that was, versus melatonin, and 87% of the melatonin infants survived, related to 65 of the ones who received standard care. A group in Spain conducted a multicenter randomized controlled double-blind clinical trial with hypothermia plus placebo versus plus hypothermia and melatonin for 3 days. All infants were studied with an AAG, had an MRI within the first week of life, and went through neurodevelopmental follow-up at 6 and 18 months of life. Clinical characteristic, laboratory evaluations, MR findings, and the EEG background did not differ between the treatment groups. The newborn in the melatonin group achieved a significantly higher composite score for cognitive section of the Bayley-III test at 18 months of age. There were no differences between the groups according to motor assessment. In a prospective, non-blinded, randomized controlled trial, all preterm infants between 34 weeks, less than 34 weeks, eligible for ROP screening were randomized into an oral melatonin or oral sucrose study. Pain assessment was conducted, and the oral melatonin was not found inferior to oral sucrose for pain management during ROP screening. And in the latest review, Canavo and collaborators summarized the current research on melatonin. Might this be an analgesic for procedural pain, a neuroprotective agent for asphyxiated infants, used to induce comfort and even have an anti-inflammatory effect on chronic lung disease in preterm infants? Given the various positive effects in controlling chronic pain and reducing oxidative stress, melatonin may be a neuroprotective agent with analgesic properties and without any respiratory depressant effects or other significant side effects. There are also thrilling data suggesting a daily rhythm of melatonin in bovine milk, with more melatonin in the evening milk. Is this something that we should study in the milk that we provide our infants with in the NICU to make them sleep better in the night? Since long, we have known that propofol should be avoided in preterm infants due to the risk of hypertension. However, in this study, 22 preterm infants received a low dose of propofol before INSURE as part of a published dose-finding studies. A multimodal monitoring of mean arterial blood pressure, near-infrared spectroscopy, and EEG were analyzed. Drug-related hypertension and decreased cerebral activity were observed, but without an evidence of cerebral ischemic hypoxia. The cerebral autoregulation capacity remained intact during drug-related hypertension in 96 of the patients, which matters. Multimodal monitoring during clinical care in the NICU may serve as a base for future modern neonatal research, including modeling, machine learning, and other advanced statistical algorithms. And aiming at individualized pharmacological strategies, we also need to include the pharmacogenetic variables into the study analysis and to conduct structured follow-up studies. This will hopefully help us toward our goal of a safe and effective use of analgesic sedatives to our sick and vulnerable NICU population. Opium is the dried extract of the exudate from the seed pods of unripe poppies. I will end this talk with this picture from a typical Swedish midsummer, when nature is so red, full of poppy flowers, signifying deep sleep according to the myth. Thank you so much for your attention.
Thank you very much, Elisabeth, for an impressive presentation in a very complex field. I'm sure you have some thoughts and questions. Yes?
Thank you, Elisabeth. I have one little question about the clonidine and studies on very preterm infants, because we use that a lot. Do we have studies to prove that it's good?
The only study that is published that I can find and I've heard of is this Hansteller publication from 2014. Okay. We have ongoing studies, or we have even stopped the inclusion, and we will analyze this data on clonidine in preterm infants and in the hypothermic infants. But I have not heard anything. Might be, but I don't know.
Okay. Thank you.
Thank you. Thank you for a great overview. I've taken pictures of a few references I didn't know yet. I have a question about, based on what we know from pain research in adults and older children, we know the extreme importance of the placebo effect around the pain strategy. Even there's evidence that in negative expectations, you can even take the opioid effect away. So has any of these studies taken into account the amount of love that was given for these children while they were treated with opioids? And so are these data actually reliable at all?
That's a very good question. And I must say that having heard you this morning, I question them myself.
That was not my goal. Because
no, I don't think they have taken that into account. Most of those studies are based, if good enough, and they are based on pain assessment.
Yeah. So we actually should create standards for pain studies where we actually harmonize and standardize the non-pharmacological settings and then do the studies again. That would be, I think, great research.
Absolutely. We have tried in our protocols, in the studies we've done here, to always have, some sort of algorithm how to treat the pain assessment result. And the issue has been, we start with non-pharmacological methods, and then if still we have a pain score result that has not been better, then we go on with the drugs. I don't know how else to do, because this is really a big issue that we can't compare the studies.
Because with that perspective, you look to the studies where you see a higher negative outcome with the morphine dose, what you showed in the beginning. Maybe it's the absence of love that created that outcome and not the dose of morphine. We don't know, actually. It's a correlation. Yeah, okay. I'm confused as ever, but maybe now on a higher level. Thank you.
I must add, I heard Professor Anand talk yesterday in a smaller group about his new ways of working with studies, and you were talking about also a multimodal approach with cameras and machine learning instruments, and maybe in that context we can include also the love and the parental support and all those things. That might be something that could add very much to our studies, the pharmacological studies.
Another round of applause for Elisabeth. Thank you very much.
Thank you.